Imagine this for a moment. A kidney transplant surgery. A huge success. The patient is stable. Everyone breathes a sigh of relief.
The immediate crisis is over.
Exactly. But the terrifying reality is that the biggest threat to that new organ, it doesn't even start in the recovery room. It can begin months, even years later, when everything seems to be just fine.
It's that silent, creeping damage, a kind of chronic immune response that just, well, ticks away in the background. And for the longest time, catching it early was almost impossible.
Which meant invasive procedures, right? A full biopsy just to confirm what you already suspected was happening.
Yes. Painful, risky, and you can't do it all the time for monitoring.
And that silent erosion, that diagnostic gap, is exactly why we're doing this deep dive today. We're looking at some really groundbreaking research.
We are. We're exploring how one team is tackling this long-term threat by combining, classic transplant immunology with the precision of modern artificial intelligence.
To find new shortcuts, non-invasive ones.
That's the goal. This all comes from a critical study out of Wrocław, Poland. It's from a multidisciplinary team. And the work was really spearheaded by doctoral student Dr. Jakub Mizera.
And he was working within the team of Professor Mirosław Banasek, who is a major figure in nephrology and transplantology at Wrocław Medical University.
And this wasn't some internal project. It was published in a top journal, Frontiers in Immunology, and it was a close collaboration with the University Clinical Hospital in Wrocław.
So a serious academic and clinical effort. And their mission, from what I understand, was pretty revolutionary.
Oh, absolutely. They wanted to find these overlooked risk factors, things you could see in a simple blood test that would correlate with the physical damage happening in the kidney.
And then use AI to make sense of it all, to analyze it in a way a person just couldn't.
You can see why they'd be motivated. I mean, the clinic there at WMU, they look after over 1,000 transplant recipients.
Wow.
And they have incredible success stories. We're talking people living 20, some even 30 years with a transplanted kidney.
That's amazing.
It is, but the goal is to make that the norm, not the exception. The goal is to make these organs last a lifetime.
Okay, so let's unpack this threat. The numbers are pretty stark. We're talking about antibody-dependent rejection or humoral rejection.
Yes, and it's the main culprit. It's responsible for over half more than 50% of all long-term transplanted kidney loss. The body it never fully gives up seeing the organ as an intruder.
Even with all the immunosuppressant drugs.
Even then, the immune system keeps producing these antibodies. And we need to talk about what that attack actually looks like physically inside the kidney. The pathology is called microvascular inflammation.
MVI.
MVI.
Okay, that sounds pretty self-explanatory, inflammation in the tiny vessels. But what does that mean for the organ's function?
It means the core machinery is breaking down. MVI is damage to the tiniest filters, the glomeruli and the capillaries around them. Think of it as the plumbing and filtration system. If those vessels get inflamed and damaged, the kidney is, well, it's losing its ability to clean the blood.
And here's something I found fascinating in the material we looked at. Until just a few years ago, MVI was actually underestimated.
It was, massively. There was a huge shift in thinking that came with the 2022 update to the Banff International Classification.
And the BAM standard, that's the global gold standard for this, right? It tells everyone how to diagnose rejection.
It's the rule book. And that update in 2022 officially recognized MVI as a severe critical warning sign of antibody-mediated damage. It was a global admission, really.
An admission that we'd been missing a key piece of the puzzle, that something serious was happening even when the usual alarms weren't going off.
Exactly. And that brings us to the diagnostic gap this research was trying to fix. The traditional method is to check for anti-HLA antibodies.
The tissue compatibility one.
Right. But you get this huge discrepancy. A pathologist looks at a biopsy slide and sees clear MVI, clear rejection. But the standard blood test for anti-HLA antibodies comes back completely normal.
That's a doctor's worst nightmare. You have physical proof of damage, but your main screening tool says everything's fine.
It is. And without putting the patient through another risky biopsy, which you just can't do every other month, you have no way of knowing for sure how bad things are getting. The tools were failing.
So the Wrocław team knew they had to look elsewhere. If the HLA antibodies weren't telling the whole story, where did they turn?
They pivoted completely. They started looking at non-HLA antibodies, so antibodies that target molecules other than those main tissue compatibility markers.
And they had a very specific target in mind.
They did. The key to this whole breakthrough was a molecule called the angiotensin II type 1 receptor, or AT1R.
AT1R.
Yeah.
Let's pause there because that's a critical piece. What does that receptor normally do?
Think of it as a dimmer switch for your blood vessels. AT1R is a protein that regulates blood vessel tone, which in turn controls blood pressure.
So if you have antibodies attacking that receptor.
You're messing directly with the kidney's ability to control its own blood flow.
Huh.
You're causing chaos in that delicate microvascular plumbing.
And the team made this incredible connection between that immune target and the actual physical process of the transplant.
Yes, this is the really elegant part of the research. They looked at something called warm ischemia time.
That's the time the organ spends outside a body without a blood supply.
Right, between the donor and the recipient. And that period, no matter how short, it causes some level of injury to the tissue.
So the idea is that this initial physical trauma, the ischemia time, it actually exposes parts of the kidney tissue, like the AT1R protein.
It makes them visible to the immune system in a way they weren't before. It sets the stage for a future attack by these non-HLA antibodies.
And the data backed this up.
It did. They found that kidneys with longer warm ischemia times were statistically much more likely to develop MVI. And when they looked at the data from 167 patients, the link to AT1R antibodies was immediate and very strong.
How strong are we talking? Just looking at positive versus negative tests.
Well, in the group that definitely had MVI confirmed by a biopsy, almost half, 46.8% of them, were positive for these AT1R antibodies.
And in the group without the damage.
Only about 24% were positive. So that difference was highly significant statistically. It was a huge signal that these antibodies weren't just background noise, they were involved in the destruction.
Okay, that's powerful evidence. But just knowing a patient is positive isn't always enough, is it? You have to know how much is too much.
Exactly right. The immune system is noisy. You or I might have low levels of these antibodies. The team needed to find the line, the point where that background noise turns into a real clinical threat.
And that's where the AI comes in.
This is where Dr. Mazera and his collaborators, like Professor Maciej Pondel from Wrocław University of Economics and Business, brought in the heavy analytical tools, not generative AI, but deep pattern-finding AI.
They used logistic regression and something called association rule mining.
Yes. So first, logistic regression confirmed the trend. It showed that for every single unit increase in AT1R antibody levels, the odds of that microvascular inflammation went up by about 6.1%.
So a steady climbing risk.
A steady creep. But that doesn't tell a doctor when to panic. For that, they needed association rule mining, or ARM.
What did ARM do that was different?
ARM allowed them to find a non-linear threshold. They divided the patients into 5 groups, quintiles, based on their antibody level. The AI then looked for the point where the risk suddenly jumps.
The cliff edge.
The cliff edge. And it found one, a really specific, quantifiable aha moment.
So what was it? Where was the line?
In the lower groups, the first 4 quintiles, there wasn't a strong connection to MVI, it was just noise. But in the very highest quintile, the risk surged.
And they could put a number on it.
A precise number. The danger zone started at approximately 12 units per milliliter.
12 omol. That's the molecular tripwire the AI found.
In that group, the patients above 12, their risk of having MVI was 37% higher than the general study population. It turns diagnosis from a guess into a quantitative risk assessment.
That completely changes how you'd manage a patient. It really fits that metaphor the team used, doesn't it? That AI isn't replacing the doctor.
It's a new kind of stethoscope.
A tool that lets you hear a very specific signal that was previously just lost in all the biological noise.
And the clinical goal is to use that signal to create an immunological profile from a blood test. An algorithm armed with this 12 MKIS threshold can flag a patient and say, hey, this person just crossed the line, they're high risk, it might be time to act.
That's genuine preemptive medicine. But is there a risk of relying too much on just one marker, on just AT1R?
That's a fair question, and the study looked at that. They confirmed that MVI was also highly associated with a more traditional marker called C4D.
So why not just use C4D then?
Because the data suggests that C4D, while useful, it lacks sensitivity. It might not catch all cases of damage, especially the ones driven specifically by these non-HLA antibodies like AT1R.
So our surveillance has to get broader. We need more tools in the toolkit.
Precisely. We can't just rely on the old checklist anymore.
Which I guess leads to the next steps. What's next for the team in Wrocław?
They're already working on it. They want to build out a full diagnostic panel. They're looking at different subclasses of AT1R, and they're expanding the search to other non-HLA antibodies.
You mean like anti-ETAR, anti-PR1?
Exactly. The goal is a single AI-driven blood test that gives a complete holistic risk profile.
And for anyone listening, for the patient, the benefit is just enormous. An antibody test from a blood draw versus a painful invasive biopsy, it could completely change post-transplant monitoring.
It's about making better, faster decisions to protect that donated organ. What's so powerful here is the collaboration nephrology, biochemistry, data analytics all coming together to find this one specific, actionable biomarker.
High titer AT1R antibodies, it all comes back to that. It's about extending the life of that incredible gift. So if AI can now tell us the exact molecular line, that 12 AUD/mol threshold, where the immune system goes from making noise to causing real damage, what does that mean for the future of treatment?
Well, it raises a really profound possibility, doesn't it? The possibility of preemptive neutralization. If we know the exact signal that's causing the problem and the exact level at which it becomes dangerous, maybe the next step is to develop therapies that can target and neutralize just that one signal
Before it causes any irreversible harm.
before the damage is done. Moving from managing chronic failure after the fact to truly individualized prevention, to making sure that transplant doesn't just survive, it thrives.